Bismillah ar-Rahman ar-Rahim. Hello everyone. Today I would like to talk about the cardiac shunts. This is the normal circulation, and in normal circulation, usually the systemic venous blood coming in the SVC and IVC will be deficient in oxygen, and this systemic venous blood will go to the arterial system of the pulmonary circulation, will go to the pulmonary artery, and it will go to the lung, will be loaded with oxygen, and it will come back in the pulmonary veins, the four pulmonary veins. So the pulmonary venous blood now will go to the left atrium, to the left ventricle, and to the aorta. So the normal circulation is the venous blood coming from one circulation will go to the arterial system of the other circulation. Venous blood of the systemic circulation will go to the arterial outflow of the pulmonary circulation, and venous blood from the pulmonary circulation will go to the arterial system of the systemic circulation. So when we have shunting, what that means, if we have a physiologic shunt, that means that the venous return of one circulatory system is recirculated through the arterial outflow of the same circulatory system. So, for example, blood coming from the pulmonary veins that goes again to the pulmonary artery, or blood coming in the systemic venous system, SVC and IVC, and this blood goes again directly to the aorta without visiting the lung. So the flow of blood from the systemic venous atrium or right atrium to the aorta produces a recirculation of systemic venous blood. A flow of blood from the pulmonary venous atrium or left atrium will go to the pulmonary artery and produces recirculation of pulmonary venous blood. The recirculation of blood produces a physiologic shunt, and the recirculation of pulmonary venous blood produces a physiologic left to right shunt. But when the recirculation of systemic blood occurs, so the venous blood from the systemic circulation goes directly to the aorta, so in that case we'll say that we have a right to left shunt. So the physiologic shunt, commonly it is a result of an anatomic shunt. So in the anatomic shunt, the blood moves from one side of the circulation to the other side of the circulation. For example, from the right atrium to left atrium, from left atrium to right atrium, from the right ventricle to left ventricle, from left ventricle to right ventricle, and from the aorta to the pulmonary, or from the pulmonary to the aorta. But the physiologic shunt can also exist in the absence of any anatomic shunt. And the example of this will be the transposition of great arteries, or the transposition physiology, as we will see in the coming slides. When we have shunt, usually some of the venous blood goes to the correct direction, and we say this blood is effective blood flow. So the effective blood flow is a blood flow that is normal, that comes from the venous side of one system and goes to the arterial side of the other system. But some of the venous blood goes to the arterial system of the same circulation, and this will be the shunted blood or the shunt flow. So we have effective blood flow and we have shunted blood flow. Of course, it is obvious that the effective blood flow is the blood flow that is normal, that keeps the blood saturated by going to the lung, and that keeps the systemic side of the body perfused with oxygen. So this is the normal effective blood flow. But the other part that missed the way is the shunted blood, which is ineffective blood flow. Now I will go through some examples of the anatomic shunts and how these anatomic shunts can cause physiologic shunt. So for example, this is an ASD. So each time the blood comes back from the pulmonary veins, so the pressure in the left atrium will be higher than the pressure in the right atrium. So some blood will be shunted from the left atrium to the right atrium, and this blood is coming from the pulmonary veins, and it will go to the right atrium, to the tricuspid, to the right ventricle, to the pulmonary artery again. So it comes from the venous pulmonary system and it goes back to the arterial pulmonary system. And of course, this part of the blood is the ineffective blood or the shunted blood, but the remaining blood that comes from the pulmonary veins and goes to the mitral, goes to the aorta, this is the effective blood flow. In this case, so this recirculated blood, the blood that goes to the lung and again to the lung and again to the lung, this is just the recirculating shunting blood, which is not doing anything. It is just exhausting the heart, and also it increases the blood flow to the lung without any reason, and this increased blood flow to the lung will make the lung plethoric, and it increase like the work of breathing, and also the heart will do more effort to compensate for this missed part of the blood flow each time. Another example of the anatomic shunts that can cause physiologic shunts is the VCD. So in this case, the blood coming from the pulmonary veins, the venous system of the pulmonary circulation, will go to the mitral, will go to the left ventricle, and now part of the blood will go to the aorta, which is the effective blood flow, and part will go through the VCD to the pulmonary artery again. So now you have part of the blood that is just recirculating in the pulmonary circulation, and it causes the same problems as with the ACD. But added to the problem with the ACD, now the pulmonary circulation is exposed to the very high pressure of the left ventricle. So the pressure in the left ventricle will be transmitted to the pulmonary artery, transmitted to the lung. So the lung now is exposed to high flow and high pressure at the same time. And we have a well-known problem. If the lung is exposed to high flow, that the lung will start to protect itself by causing vasoconstriction, which is first temporary, and after that this vasoconstriction will cause permanent changes in the blood vessels of the pulmonary circulation that can cause pulmonary hypertension. So the incidence of pulmonary hypertension in patients with VCD, when the pulmonary circulation is exposed to high flow and high pressure as well, so the incidence is higher and it is faster to develop. Another example of the anatomic shunts that can cause physiologic shunt is the atrioventricular canal defect, or atrioventricular septal defect, or endocardial cushion defect. In this lesion, there is a common AV valve, just one valve separating the two atria and the two ventricles. There is premium ACD and there is VSD, and there is left to right shunt that causes dilation of the heart. It causes plethora of the lung and increased work of breathing. If it is long standing, it will cause pulmonary hypertension. And this ventricle is prone to failure because of volume overload and dilation. In addition to that, the AV valve in a good number of patients is incompetent, and it has significant regurgitation. And in this case, there will be extra overload, volume overload on the ventricles, and the patient will be more susceptible to heart failure. This is another common anatomic shunts, is a PDA. It is like failure of closure of the ductus arteriosus between the aorta and the pulmonary artery, which causes left to right shunt. In all the previous anatomical shunts, the shunt was left to right, and the recirculation was recirculation of the pulmonary blood flow. In this case, there is no desaturation. But in this lesion, this is Tetralogy of Fallot, we will find now we have anatomic shunt that we say it is a complex anatomic shunt. It is just not a communication between the left and the right side. It is a communication like the other lesions, but there is also obstruction in the flow, in the outflow of the pulmonary circulation. This can be by subvalvular, valvular, or supravalvular obstruction, and because there is obstruction to the pulmonary blood flow, so the blood, part of the blood has to go. The blood finds it easier to go to the left side. So systemic venous blood flow coming to the right atrium, right ventricle, part of the blood will go to the pulmonary circulation, which is the effective flow, and part of the blood, which is the ineffective or the shunted blood flow, will go to the left side and will go to the aorta directly. And this blood is desaturated blood, and that's why those patients are cyanotic heart disease patients. So this is the TGA lesion. The TGA lesion is abnormal communication between the great vessels and the ventricles. So we say discordant connection between the ventricles and the great vessels. So the right ventricle, which is supposed to give the pulmonary artery, gives the aorta, and the left ventricle, which is supposed to give the aorta, it gives the pulmonary artery. And in this circulation, we say this is a parallel circulation, because the pulmonary blood flow is separated from the systemic blood flow. So just the venous systemic blood will go to the aorta and go back to the venous systemic blood, and then goes again to the aorta. And on the other side, the pulmonary blood coming in the pulmonary veins will go to the pulmonary artery. So it's just all the flow is just shunt. If we stick to the definition of shunt, all of this is just physiologic shunt. Actually, the only effective blood flow in this situation is the blood flow that will escape through any anatomic shunt between the two sides. So if we have a PDA, we have ASD, we have VCD, this is the only way that some blood from this circulation, from the venous system of one circulation, goes to the arterial system of the other circulation. This is the only way to do that. And this is very essential for survival. So those patients usually have communication between the left and the right side, PDA and ACD, PDA and VCD, and this usually helps them to keep alive, because through this shunt is the only effective blood flow that the patient has. So in this case, it is a physiologic shunt, but it is not depending on the anatomic shunt. It is a physiologic shunt because of the abnormal communication between the ventricles and the great vessels. Okay, so this is the end of this presentation. I'm planning to make another presentation to see how we discover or confirm that there is a cardiac shunt, and how to quantify this shunt in the cardiac catheter in the next presentation. Thank you for listening, and I hope you enjoyed it. And please, if you would like to subscribe to the YouTube channel, and also join our Facebook group, UK Anesthesia Network, that would be great. Thank you. Have a nice day.